I'd like to call the open session of the Tahoe Forest Hospital District to order. I want to introduce our legal counsel for today, Mackenzie Anderson. And if, Mackenzie, you could read us out of closed session, please.
Certainly. The board considered two items in closed session this evening. First, the board considered approval of the closed session meeting minutes from August 22nd, and those were passed unanimously. Second, item 5.2 was removed from the closed session agenda, and no discussion or action took place. Third, item 5.3, the board conducted a hearing under Health and Safety Code Section 32155, and the medical staff credentials presented were approved unanimously.
Thank you for that. And since do we have any further deletions or corrections from our posted agenda? Hearing none and seeing no one having any comments, we'll move on to audience input. And this is a time that our members of our audience can give public input. There are some guidelines to it. You can speak for 3 minutes. If you're going to give us some input, we'd ask you to come up to our microphone, give your name for the record, and then you have your 3 minutes to do your presentation. We cannot comment on it by the rules of the Brown Act. We do not have it agendized, but if it's something that we feel is important, we will pass it on to staff for further discussion or agendize. So do I have anybody that wants to give public comment? Please.
Oh. Thank you.
We've moved up in the world.
Yeah, high tech.
I wish you had a light here, actually. For the record, my name is Deirdre Henderson. I'm the co-lead, thank you. I'm the co-lead of 100% Renewable Truckee and the North Tahoe Chapter of Citizens Climate Lobby. I'm here tonight to tell you about an event that will take place in October that I think should be of interest to you. On October 23rd at Truckee Town Hall, we are bringing Dr. Deborah Hendrickson to Truckee to talk about the health effects of climate change on children. Dr. Hendrickson is a board-certified pediatrician who practices right down the road in Reno, Nevada. She is the author of a recently published book by Simon & Schuster called The Air They Breathe, A Pediatrician on the Front Lines of Climate Change. It is a book about the effects of climate change on children. She's a clinical professor of pediatrics at UNR Medical School, where she lectures on how childhood experiences affect long-term health. She graduated with honors in environmental studies from Brown University, served in the Peace Corps in Ecuador, and then spent 10 years as an environmental analyst before she went to medical school. She's received many awards for her leadership and her academic achievements. She's a member of the American Academy of Pediatrics Council on Environmental Health and a founding member of Nevada Clinicians for Climate Action. This event is being co-sponsored by the town of Truckee, the Truckee-Donner Public Utility District, Sierra Business Council, the Sierra Community House, 100% Renewable Truckee, and Elders Climate Action of Northern California. I'd like to personally invite each member of the board to attend this event. I think it will be an excellent learning opportunity for all of us. Thank you.
Thank you for that. Is there anybody else that would like to give public comment? If not, then we'll move on to the Employee Association. Audience input, I don't see anybody from the Employees Association, but we always like to let them know that we do have a card holder, so if they want to speak, they have that on our agenda. We'll move on to our next item, and that's the Medical Staff Executive Committee report and their consent calendar, and Dr. Koch will do that for us.
Great, thank you. We have several policies to discuss. The first 5 are policies with no changes other than correction of the risk statements that start them out, or corrections in grammar, spelling, things like that. So there are no meaningful changes to the first 5 policies, CPAP, the Incline Village policies, the telehospitalists, or the T-piece resuscitators. The next is some policy changes, and the AHP guidelines, our Allied Health Professional Guidelines, have been modified to add a new category of clinicians, which is the RNSA-C. I'll get to that in a minute. Then the next policy change is the standardized procedures that relate to first assistance in the operating room, and it is adding the RNSA term to those standardized procedures for RN first assists. And so again, I'm going to get to that next. The new privileges are for the RNSA-C. This is the Nurse First Surgical Assist certified, and this is different from the Nurse First Assist certified in that the requirements are slightly different. And the difference in the requirements are that the RNSA position, the new position, requires an RN degree that allows for a 2-year degree. An AA degree does not require a 4-year RN degree, whereas the RNFA position that we currently have requires a 4-year nursing degree. And the surgeons discussed this in detail, as it did the IDPC committee and the medical executive committee, and we are all in support of moving forward with this new position, the RNSA position, which is basically a surgical first assist that is also an RN, also certified, but it allows for an RN that only took a 2-year training program instead of a 4-year training program. When you look at drill down into the details of a 2-year versus a 4-year program, the additional courses that are missed by a 2-year program relate to leadership and research. And we felt that didn't apply to this position, and so it was acceptable. And so that is all of the policy information for you today, and we would like to request the new privileges as well as the changes and non-change policies to be approved.
Okay. Any questions from our board on any of the policies, those with no changes, those that have had changes, and some new ones?
Alice, I have a question about the surgical assist. It's not checked as to whether or not it applies to both Tahoe Forest and Incline.
Good point. I don't know that it would ever apply to Incline.
Yeah, and for right now, it was just a Tahoe Forest, so we could add it if that service is needed over there. I don't think it's needed at this time.
Right.
It was just for Tahoe Forest.
But that's a good point for us to keep in mind, that we would need to get this policy approved for Incline as well if we needed them at some point.
Thank you.
Yeah, thank you.
Any other comments or questions? Anything from staff?
I should move up to the
Oh, yeah.
podium, sorry.
Thank you for reminding me, though. Okay, anything from our audience? If not, can I have a motion to approve the Medical Executive Committee meeting consent agenda as presented?
I will move to approve the Medical Executive Committee consent agenda as presented.
I'll second, Dale.
Okay, so it's been moved and seconded to accept the meeting consent agenda of the Medical Executive Committee as presented. All in favor?
Aye.
All opposed. So the the consent agenda has been approved. Now we'll move on to 13, the consent calendar. And these are usually non-controversial items, reports, minutes, those kind of documents. But any member of our board or any member of our staff can pull something for further discussion. It'll be discussed at a later part of our meeting. So do we have anything that any of our board wants to pull?
Yes, Alice, I would like to pull 13.3.3, Chief Medical Officer Board Report.
Okay. And my assistant to my right will remind me when we get down to 17 that you have pulled that.
Okay.
Anything else that the board would like to pull for further clarification or discussion? Anything from our staff? Do I have any comments from our audience on any of the items under the consent calendar? If not, then can I have a motion to approve the consent calendar minus the Chief Medical Officer Board Report?
So moved.
A second, please?
Second.
So it's been moved and seconded to approve the consent calendar minus the CMO Board Report. All in favor?
Aye.
Aye.
All opposed? So it's been approved minus the CMO report, which we'll discuss later. In 14, we have an item for board action. It's a resolution, and we have Crystal Felix, our CFO, and Gary Hicks to present the resolution and maybe the background to the resolution.
Is this on? Yeah, okay. So while Gary is joining, this topic started back when we had our budget presentation. I had mentioned to you that I'd be bringing forward a suggestion and recommendation for a municipal lease to finance some equipment needs that we have and allow us to have short-term financing, allows us to use our cash reserve for some of our larger building projects. And so we've hit that time frame where this is becoming the timing where we want to go ahead and engage in evaluating a municipal lease. Excuse me. The municipal lease, as stated in the resolution, which I'll explain in just a second, is for a grand total of about $9 million. However, in the resolution, I believe we put 10 million, which would be the maximum. But the calculation that we're looking at today is right now about $9 million. But we all know inflation can happen, so we don't want to get caught in a pickle where we didn't put a large enough number in the resolution. The type of items we're looking at financing have to do primarily with diagnostic imaging. So as we work on what is our seismic projects, the MPC projects that Dylan has been working on, they're in areas where it makes sense to also replace the aging equipment we have or equipment that's no longer being serviced, or we're going to have service issues become out of date relatively soon. So we would use the municipal lease to cover items such as the CT scanner that's currently underway, the X-ray, the fluoroscopy, the nuclear medicine, the PT scanner or PET scanner over in the cancer center, update our PACS system. In addition, we would look at assisting with some of the building projects. So we currently have 3 projects that we're contemplating, one at the old Rite Aid space, one in Gateway, and one over in Tahoe City at Fabian. All of those will require equipment to furnish, and so we've incorporated that requirement into this municipal lease, as well as some large items that we foresee needing in various areas of surgery, anesthesia, lab, and therapies. So all of that we're projecting to be roughly about $9 million. So we've engaged Gary, who has joined us today, to provide a little education about the process of what we go through with the municipal lease, why you have a resolution before you today, and what that's establishing for us to go forward. And so I'm going to go ahead and turn it over to Gary for him to take us down this path. We're hoping to keep this to about 15 minutes, and then we'll have an opportunity for Q&A afterwards if there's something we didn't cover. A few of you have been through this before, how we do our financing. I think, Bob, you might be the newest member who hasn't gone through this with us before, so that's why we wanted to provide also a little bit of education and background. Gary?
Crystal, thank you very much. Can you hear me all right?
Yes.
Great, super. Well, thank you very much. I appreciate the opportunity to speak before your board this evening. And as Crystal indicated, the municipal lease financing is a fairly short-term financing. Typically between 5 to 7 years is the term or maturity of municipal lease financing. It generally is purchasing equipment or personal property that when affixed or installed becomes a fixture are the items. The equipment items, radiology, laboratory, are quite common as far as equipment that is typically financed by leasing companies and is quite preferred by those leasing companies. There are a couple of benefits of municipal lease financing you don't see in other types of commercial or bank financings. One is that this type of financing is tax-exempt financing. Tax-exempt in that the investor, or the lessor in this case, is able to have an exemption from both federal and likely state income taxes for the interest income that they earn on these municipal lease financings. As a result of their tax exemption, they pass on the benefits of that tax exemption through the offering of lower interest rates than to the lessee, in this case the district, for the financing. So it's much lower cost of financing than what you'd have in a typical taxable or commercial bank loan that you might see otherwise. And with that, it brings other benefits as well, and that generally we don't have any type of financial covenants. So like your revenue bond indentures that you may have outstanding or many bank loans, you typically have financial covenants relating to a debt service coverage ratio, a day's cash on hand, liquidity covenant, or some other type of leverage, maybe a debt capital covenant that you typically see in other types of financings. We generally do not see those in this type of financing. Another benefit is that typically on a revenue bond issue or a bank loan, the lender will require what we call a revenue fund pledge, which is a security interest in the depository account where the district deposits all of its revenues from the operation of its health facilities. And that then revenue fund provides a security that the bank or the bondholder relies upon in case there's ever a difficulty, either a default or a financial difficulty in the repayment of those loans that you have. In this case, the security that's taken by the lessor is actually the equipment. So the equipment is provided as collateral or security for the loan. And if there ever is a default, then the recourse that the lender would have, in this case the lessor, would be to access or take access to the equipment itself. Of course, with the district's financial resources and the district's strong financial performance over the last several years, that's not a likely scenario over the next 5 to 7 years, which is the more typical terms that you have for this type of municipal leases. We do structure the municipal leases so that they are have a term of the lease or the financing that is similar to the useful lives of the assets. So if the life of the asset is 10 to 12 years, we might look to a 7 to a 10-year municipal lease. If the average life of the assets is 7 years or 8 years, then we generally would look for maybe a 5-year term on these lease financings. We want to make sure as we go forward the process on lease financing that we engage through a competitive process to be able to determine which lender, or lessor in this case, provides the most competitive terms and conditions associated with the financing. So we prepare a request for proposal. It's a document that requests and accepts the 20 different responses from them, or criteria that we then evaluate when proposals are received, one proposal against the other, to find out which of the proposals received provide us the most competitive terms and conditions of the lease financing. Those terms and conditions we evaluate, of course, would include the interest rate, any type of a rate lock period or indexing formula, would include things like prepayment terms and financial covenants, as we discussed before, if there be any kind of special security provisions or collateral requirements that might be included by the lessor, any adverse change provisions that may be included in that, whereby a lessor can unilaterally call a lease or a loan in default because of what they term to be a material adverse change or event. We also want to make sure that there's no types of pass-through of costs or expenses incurred by the lender or the lessor in a financing like this, like sometimes many conventional loans will require by banking institutions. And then we also evaluate things like events of default and remedy or recourse provisions that would have by the lessor. All in all, we go through this process. It takes generally about 2 to 2.5 weeks for the actual submission of the request for proposal, evaluation of a credit package, answering questions and issues that come up with the proposers, lessors that are proposing the transaction. And then after that process of about 2 to 2.5 weeks, we will collect those proposal or term sheets that we received, evaluate those based upon the criteria established in the request for proposal, and come back with our assessment and evaluation of which are the most favorable and the strongest proposals received from the lessors. The resolution before you today is referred to as a reimbursement resolution. That reimbursement resolution is important because it allows us to meet federal tax code requirements with respect to the reimbursement of any cash deposits or payments made by the district that occur prior to the date of passage of this resolution, in this case today's date. It allows for a 60-day period whereby if there are any payments that are made, cash payments, deposits, whatnot that may be, those are allowed to be reimbursed by the lessor to the district as lessee, and allows you to be able to finance 100% of the equipment if that's what you desire. There, in fact, is no downside to the passage of the reimbursement resolution because it doesn't require you to reimburse yourselves for cash expenditure. It just allows for that to happen if you so choose. So it provides for greater flexibility of the district in determining what costs and expenses of the equipment, whether they be the actual purchase price of the equipment, installation and training costs, freight and sales tax, et cetera, to be financed with the lease financing in this case.
So Gary, if I could step in for just a minute. So the resolution is not making a commitment that we will move forward doing a lease. So what this is really doing is establishing a timeline, a clock. The clock starts today for that window of what we might be able to include if we move forward with the lease and submit for reimbursement. So I don't want you to think that if you approve the resolution today, that means once we bring all the lease terms and stuff to you, it means we have to move forward. That is not the case. It just sets kind of the timeline to start at the clock ticking. Gary, back to you.
Crystal, thank you for clarifying that, but that's absolutely correct. There is no requirement or mandate that you do reimburse yourselves for any expenditures, or that you even go forward with the lease financing. It just allows for that flexibility if in fact you do and when you do to do so. This resolution you have today is not even a resolution to approve the financing at this point in time. The resolution here just relates to that reimbursement of any costs and payments that are cash payments made by the district. We would expect that in probably either November or December, if we continue to pursue the process of securing financing through a municipal lease product, that we would come back with a commitment letter, a term sheet, an actual substantially final form of documents, either in your November board meeting or in your December board meeting. And then we would look to actually secure the financing probably either in late December of this year or into the first quarter of next year, 2025. That's kind of an overview of the financing process. I'm more than happy to be able to answer any questions you may have, but this is a process we've done with the district before. I know that, as Crystal indicated, many of the board members are new and not gone through the process before, but I'm more than happy to try and answer any questions you may have.
If I could add 2 points. So we anticipate doing this in 2 buckets if we move forward. So we'll have a master lease, And under that master lease, we would do two different, what I'm going to call issuance. So the first one would probably be about 3.4, 3.5 million, with the second one being about 5.5 million. That's how we have it laid out at this time. Those both could have different terms. The first one could have a specific interest rate based upon the market when we go out there with a 5-year term. The second one could have a different interest rate based upon the market at that time with a 7-year term. So they can be different, but under the same master lease, the same terms and conditions that we agreed to when we did the original financing with whoever we select. So that's one piece. The other thing I wanted to point out is once we sign documents and commitment and we're ready to fund, we'll have an initial reimbursement we'll request of, say, that $3.5 million. Maybe we get 1.5 million of that. The other 2 million would go into what would be called an escrow account. And then as we continue to spend the dollars for the items we said we'd buy, we would submit to the escrow agent who would then reimburse us out of that escrow account. And that's kind of the functionality of how the municipal lease would work. So you would actually see a line item on our balance sheet for those funds sitting in escrow, and you will see them decline as we submit for reimbursement. So just a little bit of how you'll be able to visually see that going forward.
I have two questions. Since this is structured as a lease, who has the ownership interest in the items purchased, the chattels?
The bank or whoever is providing the funds to us will file a interest with a UCC filing with the equipment itself. So their interest is in our equipment, not the escrow
However,
agent.
Yeah, but who has
The ownership of the equipment is the district. The district owns the
Oh, I
equipment
understand what
throughout
you're
the
saying,
lease.
sorry.
Yeah. And then the lessor takes a security interest through just what Crystal said, a UCC filing and a security interest in the equipment.
Sorry, Bob, I misunderstood your question, so.
Yeah, that's what, that answered my question.
So Gary and Crystal, Dale here. As you know, we have sufficient funds in reserve to cover a $9 million purchase. Why is it advantageous to incur borrowing costs when we have those funds available?
I'll answer that.
Yeah.
So, as Dylan has informed the board, the 3 projects alone for Rite Aid, Gateway, and Fabian are multiple millions of dollars. I see it financially, and you saw it in the forecasts, that to do long-term financing for building projects is not favorable for our financial ratios in the long run and puts more pressure on the financial direction that this organization would have to take to afford 30-year bonds or things of that nature for construction. So I would rather take our cash reserves and use it towards the building projects, which would be much more expensive to finance, than do short-term financing and finance our equipment instead. So our ratios demonstrate a much better position by doing short-term financing than long-term financing because we have some very large projects ahead.
And the ability to be able to put more equity towards the building projects by financing the equipment allows you to be able to secure lower cost financing for the major projects that you have. In addition to that, as we talked about before, the lender or the lessor in equipment financing does not take a revenue fund pledge. So it leaves your full revenue fund pledge available to bondholders on a revenue bond issue, which provides them for an enhanced security position. Also, we're seeing more and more in today's environment with the way that healthcare has been going. Tahoe Forest Hospital District is an anomaly, quite frankly, in the marketplace. Most hospitals are struggling financially right now. Many hospitals that were investment grade rated, even A-rated credits, have difficulty in even complying with their financial covenants, either a debt service coverage ratio or a days cash on hand or both. And many lenders are looking for healthcare providers to put more equity into their project. And so our ability to put more equity in the project by financing this equipment allows us to be able to lower our borrowing costs on that type of a long-term financing that would be generally through a revenue bond issue.
If we need to take that route.
Yeah.
I'm trying to avoid that route.
Even better, even better.
Yeah. So we hope after, assuming you approve the resolution tonight, Gary is prepared to send out the RFPs to the 20 or 30 institutions he's identified. We hope to have that summarized and some information to be able to bring back in October from that RFP process. And then, like he said, it will be November, December, where we would move towards final documents and final approval to execute the lease.
I have one other question, and that is, under the terms, is it possible, if we were in the financial position to do it, to pay this back early without penalty?
Yeah, that would be one of the terms, is there any prepayment penalty terms that they would be looking to include in the lease? That would not be acceptable. That would, in my mind, rule them out from an institution, or we would negotiate that out if their other terms were quite favorable. Sometimes they're willing to negotiate, like the last time we did this, they wanted us to put $1 million into their bank in like an account, which is the one we moved to the 2% interest rate that's still sitting there as part of an agreement in the negotiation, and that gave us a rate reduction by doing that, and it's really no big deal to put $1 million into the bank account to get a reduced interest rate. So there will be some terms that will come forward that might be negotiable.
Okay, thank you.
Crystal, the alternative, just a standard equipment lease, right? I mean, we could go, but this is just more favorable to do the municipal.
It is because of the tax exempt component that
Okay.
allows us to possibly get even more reduced rates than what we typically would just, if we just chose to go out to the market ourselves.
Yeah, okay, thank you.
And we would look favorably by these lenders because of what our financial positioning is.
Oh, yes. So the 10-year forecast in your budget binder that also look 5 years backwards at our audit and provide all those ratios, that's the analysis the institutions would be looking for on the financial stability of our organization. And I have no doubt they will want to come to the table.
Good to know.
Without question, absolutely.
Will these lenders periodically want to see our current financial situation to ensure that?
We've provided our audit in the past to the previous municipal leaseholder that we had, but other than that, there was no additional requirements.
Any comments from our staff? Anyone from our audience want to make a comment? If not, then I think that Crystal would like to have a motion to approve the Resolution 2024-05, an official intent regarding certain capital expenditures to be reimbursed with proceeds from an obligation. Is that the motion that you'd like?
That sounds great.
Sounds great.
So could I have a motion? Can someone move to approve the motion as stated?
Also move that we approve resolution number 2024-05 as stated.
A second?
I'll second. Dale?
Okay. So it's moved and seconded to approve the resolution 2024-05 as presented. All in favor?
Right?
All opposed? So we have that for you, and if we need to do that, or the clock is ticking, I understand.
It is. So Gary, thank you for joining us tonight. I know you weren't in the best spot to be able to do this, so I appreciate you joining.
I hope he's not driving that, I hope he's not driving that car.
No, he's at Disneyland. So,
But thank you guys, that was a very understandable presentation.
Yeah.
I really appreciate it from
And-
both of you.
we'll see you in October with more information.
All right, thank you again.
Thank you.
Thank you very much.
Now we'll move on to 15 items for board discussion, and we have this evening Dr. Brian Parrish and Dr. Dillon to discuss behavioral health. And welcome.
Just a quick little, these little buttons here when you're talking. Awesome.
Well, I'm Brian Parrish. Nice to meet you guys. Thank you for having us tonight. We wanted to come by and give you an update on all things behavioral health, where we're at currently and where we're hoping to go, and then answer any questions that you guys might have. So we wanted to start with an introduction. I'll turn it over to Dr. Dillon.
Hi, everyone. Nice to meet you guys. My name is Gippin Dillon. I joined the team here about 2 months ago at this point, and excited to be here. My history is basically as a board-certified psychiatrist and board-certified child psychiatrist. My role here right now is as the medical director, and I also see patients for our psychiatry team. So it's exciting for us to be able to present to you guys today and answer any questions, because I hear that you guys haven't had a presentation from our department in quite some time. So we're looking to basically just kind of update you guys on what's going on, and we're here to answer any questions as well.
And I'm Brian. I'm the operations director for behavioral health. So the hospital's moved to a dyad leadership model. So all things clinical will be Dr. Dillon, and then operations will be more of my wheelhouse. I was with Tahoe Forest for about 4 years prior to coming back on July 8th in the multi-specialty clinic. So I'm happy to be back and working with the team.
So just to talk a little bit about what we provide as far as behavioral health services to the community. Basically what we're doing is we do mental health evaluations on patients that may be suffering from things like depression, anxiety, ADHD, schizophrenia, bipolar disorder. Basically we do the evaluations, we try to get the diagnosis correctly, and then we go on with continuing with treatment for these patients. When it comes to the diagnosis, that's something that I do routinely. We have nurse practitioners that do that as well routinely, and we have therapists and psychologists on our team that do that pretty routinely. So once we've got the diagnosis, we tend to work with the patient. We are looking for a model where we can provide them with both therapy and medication management services. Those lead to the best outcomes from all of the literature and basically all of history. And so it would be me and our nurse practitioner staff that actually provide the medications. We follow up with the patients, pretty frequently, make sure there's no side effects, make sure that they're getting better. And in the meantime, they're seeing their therapist usually weekly or every other week, as an adjunct to our treatment plan. And we do both individual and group therapy, which I think is awesome. Not every place that I've worked in has actually been able to offer group therapy, but we have some really talented and willing therapists on our staff that are willing to do that, and sometimes patients feel more comfortable in that setting. So we're able to provide multiple settings for the therapy services. One exciting thing that we provide, again, that I haven't seen in any of the places that I worked in the past, is we actually have a S-ketamine program that was, mostly, for the most part, developed by our nurse practitioner, Jonathan Lowe. And we kind of, since me and Brian have been here, we're just kind of trying to support the process and get it to the next level. S-ketamine basically is a new medication, a relatively new medication. It's used for treatment-resistant depression. So the patient who's tried multiple medications and tried therapy services and nothing has really been helpful for them. It's almost like a last effort for them. And it works amazingly. It works great for suicidal thoughts as well. It can immediately abort suicidal thoughts after one treatment. So it's a great medication. I think in the long run it does really decrease healthcare costs, because rather than having patients showing up to our emergency department, multiple times in a week, or doing something worse where they need more medical care, basically if we're able to kind of nip it in the bud, we're able to really reduce the long-term healthcare costs associated with the mental health disorders. We also provide, which I think is awesome for our patient population here in Truckee, as well as neuropsychological assessments, because here in Truckee we have more than the general population in other places. We have more head trauma injuries because of biking and skiing and all of this stuff that we like to do out here. So TBIs, traumatic brain injuries. So we have a neuropsychologist on staff who can actually, assess for any cognitive dysfunction, any psychiatric illness associated with the brain trauma, along with other things such as like adult onset ADHD, autism, which is becoming more and more prevalent, unfortunately, every year. So to have a neuropsychologist on the team is really, really just, it's a huge part of what we do, and it's something that, again, most places don't really offer. So we have actually a lot of things that, aren't necessarily universal and are actually pretty unique to our program that really, and to speak to that, I mean, she's booked out many months at this point, so, the services are being, adequately used. Another member of our team who, again, is very unique and very difficult to find, and we're lucky to have, is a developmental pediatrician. And so his name is Mark Ruggiero, and he's basically, his field is a very rare field to find. And so basically he's able to treat patients with ADHD, which is, more common and more providers can treat, but, he can do a lot of treatment for autism. He can do a lot of treatment for developmentally delayed patients. So he works with the kids mostly with either developmental delay or mental health issues. So we kind of have a really good, comprehensive system going. We don't have as much staff as, we would like at this point. I think Brian will go into that, but the staff that we do have are, a tremendous asset to our team. And so I think, I started here about 2 months ago, Brian as well, so I think we're really coming into a really good situation.
Awesome. And just wanted to get into our patient volumes. I know this is going to be a little bit hard to see, but this graph here is just our last 6 months of patient visits. We really wanted to show you this because we do have services being offered at 4 different locations. So the yellow line there is Incline Village. We had a nurse practitioner, Katina Varzos, and a therapist, Betsy Glass, over there. We are currently replacing Katina's position. We have an offer that's been accepted by a new nurse practitioner, so she'll be starting in December, so we're very excited about that. The blue bar is the behavioral health MOB, so the medical office building, which is 2nd and 3rd floor. We have services on both floors there. It's been really nice to have Dr. Dillon on the 2nd floor where all of the primary care providers are at, so he can really be integrated in with the primary care providers. And then we also have services being offered on the 3rd floor near the pediatrics office. The largest number there is the IM card behavioral health, so kind of that pink line there. That is Jonathan Lowe and Layla Gerari, so those are the medication-assisted treatment services and the S-ketamine clinic. The reason why that bar is so much higher is because with the S-ketamine clinic, Jonathan can actually have 3 patients in a room at the same time, and really basically it's self-administered medication, and then he's just doing the supervision. So that's why that volume is so much higher there, is because he could technically have 40 patients a day on his schedule because he is running clinic 3 at a time there. And then the TFMC psychiatry clinic is in the Levant building. That's where the neuropsych testing is happening at this time. So about 4,700 visits over the past 6 months, and that number is a bit inflated because of that S-ketamine clinic that we're offering there.
Are those unique patient visits, or is that?
Correct.
Okay.
Yep. So a lot of those are repeat patients. So for the people who are getting the S-ketamine treatment, they are coming, once a week for an extended period of time. So unique patient visits, but it is a lot of repeat patients.
Okay, thank you.
And for staffing, as Dr. Dillon mentioned, we did put a target state and then what our current vacancies are there. So currently we do have the psychiatrist as the medical director, myself as operations director. We'd like to get to a spot where we have 3 NPs or PAs to help support Dr. Dillon and the therapy team. 1 clinical psychologist, that's Dr. Schauder that we have on our team, the neuropsychologist, a developmental pediatrician, and then the behavioral health intensivist. This is the part that's actually the therapy staff. So those are the ones who are providing the individual therapy and the group therapy after they've seen one of the medical providers. We have a behavioral health navigator, which serves as our referral coordinator. So she's scrubbing through charts, making phone calls to see who is the most appropriate provider for the individual to see, and then our medical assistants as well. Our current vacancies, we have 2 NP/PA, so the mid-level practitioner vacancies. One of those has already been an accepted offer, which will be starting in Incline in December, and then we're actively interviewing for that other nurse practitioner or physician assistant right now. And then we have 2 behavioral health intensivist positions, one of which an offer has been made and accepted, so that individual will be starting in December as well. So we're excited to see that the program's growing. We're getting more access to care by bringing on these new providers, because we know that's been the big feedback from the community is it's hard to get in to see behavioral health and psychiatry. So just a list of our current priorities for myself and Dr. Dillon, now that we're both kind of getting our feet wet and been here for a few months. Main goal is increasing that access to behavioral health and psychiatry services. So by having a full-time psychiatrist, that access has already opened up, and we are actively taking in referrals for psychiatry at this point. We really want to look at improving the referral process, and this is really just about making it more efficient. So right now, in order for somebody to be seen by our department, they do need that referral from their primary care provider, and we want to make that process a little bit quicker than it is right now. From what we've seen, it can be a fairly lengthy process by the time the referral's been sent by primary care to the time they get in with us, so that's what we're working on with the consulting company Vizient right now. Same thing with the intake process. We want to standardize that. We had in previous iterations, we were doing an in-person intake visit. Then there was some, paper packets and screening tools being used. So we want to standardize that across all of our providers in order to make that a more efficient process. We want to increase our employee engagement. We have had some staff turnover in this department. We've recognized that as an issue. We want to retain our staff that we have and help with recruitment as well. And then really exploring collaborative care models. So we want to find the best model that works in the rural health clinic system, where we can collaborate with primary care, pediatrics, urgent care. Like I said, having Dr. Dillon on the same floor as all of those providers is a huge help, so they can do kind of one-on-one consults. But we want to find a way where, as a business, that we can actually be billing for these consults that we're doing right now, just kind of off the cuff. So we want to make that more efficient as well. I know this is going to be really hard to see as well, but we are working with Vizient, which is a consulting company that's really helping us solve a lot of these problems that we've identified with our efficiencies. So this graph here is just a roadmap for which priorities are we going to address first, and then basically what our next 2 years looks like. So right now we're working on the referrals process, the intake process. A big project that we have going right now is how to manage suicidal ideation phone calls. So if somebody calls with suicidal ideation, 9 times out of 10 they're going to end up with the patient access center. So we're providing training to those staff who are taking those calls so they feel comfortable in knowing where to go, whether that's 911 or 988, any of the crisis services. So we're doing some training there right now. And then just refining our reporting structure to meet that dyad model that the hospital is going to as well. This just shows where our current status is on a lot of these first 7 priorities. So we're about halfway on the majority of these, 60 or 50% on most of them. We did have one little hang up on the 340B strategy. So what that is about how can we get some of that S-ketamine, the Spravato medication, at a cheaper rate and actually stock it here at the hospital. Right now we're having to order through specialty pharmacies, but we want to be able to house that medication here, get it to the patients quicker so there's not that long wait time. And that process has already kind of taken place. We just got the certification as of last week. So now we're going to start the testing phase and making sure we get all of our billing codes in place. The suicidal ideation calls management, we've already kind of done our testing and our kind of root cause analysis there. Now we're moving into the problem solving phase. And that's kind of the same with the engagement and referrals processes as well. So that is all that we had. We did put our contact information if you guys have any follow-up questions, but we'd be happy to answer any questions that you have about our service line or our future state.
Well, I want to thank you for your presentation. I think we've been waiting to hear about what's been happening in behavioral health. We've always had it on our focus, but never knowing what was going on specifically. I really appreciate your behavioral health roadmap. It gives us a timeline to be watching so that we can ask you to come back and say, okay, where are you with this roadmap? I think most of the dyad services are using some kind of visual to look at where their goals are and how close they are to getting to them. So thank you for that, and thank you for our community for what you do for behavioral health. I was just at another meeting earlier this month about suicide and anxiety, and what's being done with that in terms of collaboration within the community and services that are being provided. I had not heard about the clinic and using the convenes. So thank you.
I had a couple of questions and also a comment. And one of the things that's nice from our point of view is seeing the dyad model start coming into place and seeing how both the team building that produces and I think the results. So that's really nice to see, and I thank both of you for working on that. The other thing is to see how the Vizient program is actually working at the ground level to produce better results more efficiently results in less roadblocks. And I can see how you're working through those issues here. And that's also another great thing to see. My question has to do with trying to understand our community. And I'm just wondering if there are any factors of our mountain environment here that are contributory to some of the conditions that you're seeing in behavioral health?
Yeah, I think, there's the mountain environment sort of attracts a certain type of person. We see a lot of extreme sport athletes, whether they're transient or not. So, like I mentioned earlier, there is a lot more head trauma that we see here than we do in other places. Another thing that I've noticed here is the extreme sports tend to attract a lot of patients for certain reasons, and one of the things is there's a higher level of ADHD that I find out here, and so if you look at the dopamine hypothesis of ADHD, basically that's why we prescribe stimulant medications, which sounds counterintuitive because you're thinking, why would you want to stimulate a patient who's already very hyperactive? But it actually has the opposite effect and actually calms them down and is able to make them focus. In that same way, they look to self-medicate as well. And, so extreme sports, biking and skiing, these are ways to kind of self-medicate and give them that dopamine rush. So I would say two of the more common, and a third one is alcoholism. A lot of alcohol use disorder out here that we found, and I don't know exactly why that is. I can't explain it, but I would say traumatic, head injury, ADHD, and alcohol use disorder are some of the things that I've seen that are more prevalent here than I've seen in other places that I've practiced.
That's interesting. Thank you.
Question, do you work directly with the schools in either diagnosing or treating any of these patients?
Yeah, so a couple of our providers that have worked here previously are now active employees with the school district, so we do have a really good relationship with the school district. Right now, what we're trying to work through is a lot about the release of information. So if there's a child who's got ADHD who's working with counselors and therapists in the school district, but also seeing Dr. Ruggiero for testing here, we're trying to figure out what the best way is to collaborate with them with, maintaining HIPAA policies and all of that. So yes, we're actively working with the school board. A lot of our providers do meet with the school district fairly regularly. Now we're trying to figure out how we can best share information with them by maintaining confidentiality as well.
And we don't really have necessarily an official tie, but we do have a lot of community outreach programs, and we have one that our nurse practitioner, Jonathan Lowe, he actually goes to the high school and does talks about substance abuse and talks with the kids over there. So there is the community outreach aspect, and that's just an amazing part of the staff members we have is they really are involved in the community. They've lived here for a long time, so they really go out of their way to go above and beyond for to do these things that they're not basically getting paid for, right? So.
Yes, thank you for the important work that you're doing. This is, it's a young program, but already so impactful. And I really appreciate that. And I think that we will have as high a caliber outpatient behavioral health and mental health program as we have with everything else. My concern is around inpatient. Correct me if I'm mistaken, but I understand that there's quite a limit in inpatient beds within the two counties. First of all, is that correct? Is my impression true? And secondly, is there anything that we're doing with the county systems or what have you to help them to expand their beds?
So that's definitely true, but I wouldn't say that's limited to the area that we're in right now. It's basically a national crisis for the most part that there's a limitation on inpatient beds. I've practiced in Hawaii and I've practiced in New York City. I've practiced in the Valley, Central Valley of California. I've never been to a place where there was a sufficient amount of inpatient beds for the amount of patients that need it. But at this point, our program is still in a relatively in an infancy stage, and we're not, able to work on starting our own inpatient unit here. But me and Brian have been meeting with the county and just sort of seeing how we can help them and they can help us. But at the time, there is no really great answer. It's just that, we do our due diligence. We do the process. We have the patient in the emergency room, and unfortunately, sometimes they have to wait days to find an inpatient bed. But I will say that the county is very interested in collaborating with us and so far has been doing so. So that's something I think we can explore a little bit more, yeah.
Thank you.
Any other comments from our board? Any comments from our staff?
I would just quickly say there's a lot of excitement about these two gentlemen joining the team, and really just everything you see tonight really is because they're just passionate about what they do, and I hope that comes out tonight from their presentation. We're very excited to have both of you. Appreciate it.
And we did get a reading for our meeting today that talked about the number of inpatient and hospital required, that there aren't enough, and it doesn't look like there's ever going to be enough. So again, trying to do it the best we can on an outpatient basis, and I think more therapies are coming down the line that will be helpful to our behavioral health program. Anything from our audience that they want to comment about? Well, we thank you again for that great presentation.
Thank you.
Yeah,
Thank you, gentlemen.
great stuff. Makes you wonder what.
And
what
now
did
we
do
have-
before?
We have Scott Baker. Scott Baker is going to tell us all about clinic visits. Thank you, guys.
All right. Good evening.
Good to see
Good
you.
evening, Scott.
Yeah. Okay. Here today to follow up on an item that came out of the board retreat. There was a request for more information, more transparency on clinic volumes and efficiency. This report is meant to be kind of an initial data presentation to spark more conversation on that item to make sure that we're meeting your request. This particular report I'm happy to provide on a monthly basis. I'm also more than happy to go back to providing a monthly narrative and report, as I did up until a few years ago when that stopped, outlining where the growth is, where the concerns are, our recruitment plan, our recruitment activity, and things of that nature. If there's anything else I can provide, I'm happy to. This is a snapshot of our month-to-date, year-over-year comparison with different sources of clinic volumes. I can provide more detail, less detail, whatever you prefer. Any immediate questions?
Yeah, I wasn't here when you gave those summaries, and because the overall healthcare system is seems to still be growing, and in the past has grown rapidly, it's kind of helpful to have that perspective to kind of understand where we are in that process and, you know, how that's being handled. It often seems to me that in a way we're kind of a new healthcare facility, because what we were 2 years ago or 4 years ago is not what we are today. Mm-hmm. And with things changing at that rapid rate, it's kind of helpful to see where the patient volumes are and to kind of understand from that what the community needs are. So I find that information quite helpful.
And I agree. I've been here for 8 years, and that year we saw about 60,000 clinic visits. This year we're projected to see 160,000. So that's a dramatic growth over an 8-year period by any measure. And so seeing those growth curves and where we are growing, happy to provide those details on a monthly basis moving forward.
Yeah, I would encourage that. I don't know about other board members, but that's certainly something I would advocate for.
Happy to.
And then, Scott, also, you have on your chart what's happening in primary care. I guess you call it IM.
So to be clear on this report, IM is our IM card office. The Truckee Clinic is the primary care clinic to include both primary care and urgent care.
Okay. But what I was looking at was the totals for urgent care versus primary care. Sure. And I wondered if they go to urgent care, there's usually some follow-up that may happen. And so do we get them tied into a primary care?
Yes, both for urgent care and emergency visits. Every primary care office holds next day follow-up appointments so they can get in right away. So depending on the situation coming out of urgent care or the ED, they can get in the next day for a follow-up.
Oftentimes, urgent care is used as their primary source of care. And I wonder, is that going to change, do you think, as people get primary care providers?
It can, yeah, it will change their behavior, but some demographics only use urgent care. They don't establish with primary care. So that's a challenge that we need to educate our community on. But generally speaking, urgent care, well, I can tell you urgent care has more than doubled in the last 2
Yeah.
years. That is mostly a function of the capacity. We've doubled our capacity both in Tahoe City and here in Truckee.
Okay, that has grown even more than primary care has.
Correct. Yes. Urgent care and primary care have both grown tremendously over the last couple of years. Primary care mostly through hiring additional providers and additional space. So I don't think we've met the demand for urgent care yet. Many of those patients are staying here in the community rather than driving down to Reno or showing up at the ED with non-emergent situations. So urgent care is still growing, and we're trying to meet that demand. And by the way, you'll hear a presentation from the urgent care team next month.
Okay.
Oh, great.
Okay, good. Scott, I'm trying to make sense of this Olympic Valley and what's going on there.
Yeah, sure.
The numbers are a bit confusing.
So it's important to know, there's some caveats to this report. Last summer, we kept Olympic Valley open for primary care visits
I thought we did.
because we were out of space here in Truckee and needed some more capacity. This summer, it's been shut down.
Yeah.
So that's been the difference in numbers you're seeing.
Okay. And then looking across, though, Tahoe City really grew 822 to 1274. That's a big jump.
We were able to get a third provider in there, where previously we'd only have two. We repurposed a room and took over the office next door, which used to be a print shop or print store. We took that over and got some administrative space out of there, so we were able to have 3 providers on any given day now.
So as we build out the Dollar Hill facility, do you expect those numbers to even be larger?
Yes. Depending on what happens, but the current theory is that we can pull primary care and put it in Dollar Point and use the current facility for all urgent care. So in the shoulder seasons, we may not need 3 providers, but in the winter and the summer, we'll probably have 3 providers there providing urgent care.
Oh, so the intent is for urgent care, you'll continue
Correct.
to keep it open?
Correct.
Okay. But limit it.
You may have already answered this question, but I mean, there are some pretty big swings, minus 55%, 55%. You had one provider and it can swing that number, right? And so we just have a small N on a lot of these. I mean, if we had 200 providers, you would see,
Correct.
Yeah.
It's limited to this month. So example,
Yeah.
sports.
I was looking more at the year-to-date, but
Sure.
even there, you get some big swings.
Our sports medicine physician went on a 3-month vacation, and that
Boom.
makes a big difference.
Okay, that makes sense.
Anything else I can address today, but I will provide a more detailed report with narrative for next month.
Okay.
So
Before you leave,
you can expect that in the consent calendar.
I just have an additional question, yeah.
That's where I'd expect to see it.
So we-
I just think it's a report that's really relevant because it kind of drives a lot of the other things that are going on.
Absolutely. Sure.
How does this tie in, though, understanding where there's unmet need? Right? We know where we're growing, and if we continue to grow, but is this mapped to other data where we say, hey,
It is.
where's the cap, so to speak?
Correct. We've used the Krentz report. You may have heard us refer to that. That original report is now getting 4 or 5 years old now, but that provides us claims-based data to tell us where the greatest need is in the community.
Okay.
So if somebody lives here and goes somewhere else for that care, that's captured in that report. So we've used that as our recruitment plan to try to meet that need.
Okay.
It is 5 years old now, but we're working on some projects to give us more up-to-date information, which we'll continue to use to guide our recruitment. One is using Krentz, and one is more of a almost in real-time data resource that we can use in the future recruitment efforts.
Do you want to speak, Louis, more on that?
Yeah, I'll just quickly
Say with the Krentz report, Scott's very accurate and state we can only use so much information from that 2018 report at this point. So we actually will be starting in October, working with Krentz for the development of a new report that will be done in February, and we will present to this board in March. And then Scott and his team and many other teams throughout the organization will begin to use that. And then, as Scott mentioned, we are looking into the future, because that is a snapshot in time, of a more real-time tool that we can use quarterly to get good information on leakage, where people are going, and also in efforts of hiring. So I look forward to that report in February, and then, of course, a more real-time tool, likely next year to maybe even the following year.
Anything from our staff? You don't want to chime in, Dr. Evans?
No, I think it was handled very well.
Thank you.
Just a quick question, because sometimes the way we label things isn't always clear of what locations we're talking about. I'm wondering if in his monthly report, if you would like kind of an address definition or something, so you guys know exactly kind of how we've nicknamed things, if it makes sense. So I just thought I'd throw that out there if you needed any
I can do that.
clarity on that.
It's a good idea.
Sure.
More clarity is always good.
I'll provide a glossary of terms.
Yeah, and no abbreviation.
Absolutely, happy to.
It also takes me a while to figure out, it's not age-related, right? PC, UC, SPC,
We like our acronyms.
I know.
Yeah.
We don't.
Loud and clear. I'll define those for you.
Well, thank you. And
Absolutely.
we're looking forward to seeing you again.
Absolutely.
And giving us more information.
Great, thank you.
Yeah, good job, thank you.
Did we ask the general audience for comment? Did we ask the general audience for comment as well, or just staff at that?
Oh, no, we asked for, okay, now I've lost my place, I'm sorry. These are for board action 16. And our first one is Resolution 2026-06 regarding supporting of a LLC or a nonprofit. And Ted's going to do that with us.
Certainly. Chair Wong, Directors, Ted Owens, Executive Director, Governance. The resolution before you is the result of a policy that the Truckee Tahoe Airport District has when they consider utilization of public funds in the form of a grant or sponsorship. They like to have those analyzed by two other agencies and approved by resolution. So we've been there before with the airport district, and we reviewed what they're going to do. And for us, it actually works out well with a contribution to Inner Rhythms, being a dance organization for young people and all walks of life, actually, because it is health related. And so we very strongly would recommend approval of the resolution before you tonight so they can move forward with the granting of their funds. This, again, is not funds coming from us. It is funds that would be derived from the airport district.
Just a broader comment on that, which is that the governance throughout this area is really done by districts. And I like seeing that the districts are talking to each other and trying to coordinate programs, because we all represent the same constituents, and we're just trying to do, the best we can for the community. So when we talk to each other, it kind of helps, I think, all of us understand what's going on and what can be done. So just a pitch for that.
Well, thank you for raising that issue. This is an example of collaboration, and we're pleased and proud to do it.
So, Ted, I've always been a little confused by the spending budget of the airport. I see you grinning. For years I sat on the grants committee of the Truckee Tahoe Community Foundation, now the Tahoe Truckee Community Foundation, and we regularly saw programs and projects like Inner Rhythms come before us, and we approved them. We thought that was a perfect opportunity for grant making by the Community Foundation. Tell me why it's appropriate for the airport to be giving money to Inner Rhythms.
That's a very good question, Director Chamberlain. You would ask me to speculate, but they do have policies with respect to utilization of what they would call community funds. They have several buckets. I think Louis is chomping at the bit to jump in on that.
Well, yeah, there would be some speculation there on our part, so I don't know that we can answer that with any kind of certainty. But I do know that, in conversations, they do try to really look at the scope of how they can assist the community based on various ways. Like, they're very involved in fire management at the moment, right, and contributing to the assistance of removing of fuels, ground fuels,
And essentially, the way they look at it is, their airport is used by landowners or people who own homes, and if there was to be a big fire, they may end up not having those people in this community. And so they can really make some ties and nexus when they need to. So I think other than that, we might be speculating, though.
But to Inner Rhythms, it has nothing to do with fuels management. I remember when we were asked to give to the city for the construction of the swimming pool and
Park and Rec District.
Park and Rec District. And we as a hospital board agonized over it because obviously there's a health benefit to a swimming facility. And the arguments were that it is health related. And we still, despite the fact that we could justify it from a health standpoint, we still decided, no, it's not, that's not in our lane. And but as I say, I've seen several times where the airport has come out with promoting and funding projects, and I go, how does that, they're supposed to be landing airplanes on a tarmac. And
They are, Director Chamberlain, they've been involved in many different types of things. For example, they've done work with the Land Trust, for example, Waddell Ranch, which was a big project, and partly because there was, I think, a density capacity of 1,300 units that could have been built out there, and that's in their flight path.
yeah,
Okay, so they look at safety, they look at well-being, and then they also have a community engagement component that they work with as well as a governmental agency.
all that I understand.
So while they may not utilize all of those funds always on their property there, they do feel an obligation to give back to the community in a collaborative fashion and be supportive of things like
And I
this.
think as a board, we may not be supporting buildings and brick and mortar, but we do support programs. And Inner Rhythms is only asking us to support them going forward to the airport for money. And I do have to say, their programs really reach out to the health of our community. They have special needs children and adults.
And adults,
Who
yes.
come to the dance program. And to see them perform in front of an audience just warms your heart. They get such joy out of it. And so in that sense, it is the mental health and the behavioral health of our community that it supports, and also giving young people an outlet for some of their energy, some of their anxiety. And I just really support the Inner Rhythm trying to do these things for our community. So I would like to see that we do that if that's what the board's wants to do.
It will enable them to move forward.
Yeah.
The ultimate decision is the airport district.
Any comments from our staff? Any dancers in our staff?
I would be in need of mental health services if I was required to dance
Or
under
we
any
might,
conditions.
actually, if
Yeah.
we watched you dance, yeah.
Any from our audience that would like to make a comment about moving forward with this resolution? All right, if no, and no further comment, can I have a motion to approve supporting the airport district funding support of the Inner Rhythm nonprofit dance studio?
I'll move to approve resolution number 2024-06.
A second?
And I will second that motion.
Okay, so it's been moved and seconded to approve 2024-06 for Inner Rhythms nonprofit to be supported by the airport district funding. All in favor?
Aye.
All opposed? So the motion carries and the resolution can go forward to Inner Rhythm and the airport.
Thank you.
I don't think you need to go too far, Ted, because you're going to do Resolution 2024-07, endorsing the Climate Transformation Alliance Charter.
Correct. The resolution before you is a part of our environmental stewardship journey that we've begun. The Climate Transformation Alliance, which was included in your packet, is an entity that consists of local agencies, businesses, individuals, and they have a very strict plan for membership in the organization. And for our first step, I've been attending meetings, but our first step would be adoption of the resolution before you, which endorses the CTA's charter, which is in your packet. And that addresses many things under membership and requirements and expectations. It outlines governance arrangements. And so I would recommend to the board that we take this action as a first step. The next step would be formally applying for membership, but we have to have this in hand in order to do that. So I would recommend that the board adopt this endorsement of the Climate Transformation Alliance Charter.
Any comments from our board?
Yes, I have a comment. I'm glad to see us moving in that direction. I think it aligns us with other districts and with the town in the community. It's certainly a important, incredible future that we face with climate change, so that whatever action we can on a local level take, I think we should be taking. And I'm glad to see that we're working with others in our geographical area on that. So thank you for getting us started on that path.
Any other comments from our board?
Yeah, just a question.
Yeah.
If we taken a look at, the resource requirements to support the work.
Very good question. I had a feeling that was going to come up. So it's the way that the alliance works is you do have the opportunity to opt out of something if you decide to do that. The one thing that's very well written and put into their charter are off-ramps. Understanding that agencies, for many different reasons, may have to opt out of a particular project. And so it would be kind of project by project based. And at this point, what's been, conveyed to me is that there's not going to be a direct invoice right off the bat that says you have to continue to do this on an annual basis. We will have financial requests and bridges to cross in the future as a member, though.
To go along with his comment about resources, it also requires that a elected board member has to be on the committee as well as a staff, staff person. And that the part that I like about the contract or the charter is that you bring your plan of reducing green gas emissions to the committee or to the organization, and you just review what your plan is. So it really makes us accountable for our plan. Mm-hmm. My question is, do we have the plan well enough developed that we would be able to take it? Or is this just going to the charter saying we approve it, but we need to get some things in place before we become participant members?
Yeah, so absolutely the latter, right? So ultimately, we, as Ted said, we're kind of in infancy stages here of this journey. And so, we have some thoughts here in terms of potentially resources internally that may need to join our team, as well as that, our staff is very passionate about this work as well, or at least a number of them are. And so we're already hearing from a number of staff members about projects they'd like to be involved in. So just trying to refine, what that pathway looks like and really come up with a calendar, essentially, of doing that good work. We also need to educate ourselves to state laws that hospitals are, that are really only imposed on hospitals, right? So hospitals have to be open 24/7, can never close. There is no keys to the front door of this hospital, right? And with that said, there's going to be, I look forward to actually having discussions with CTA about educating them just as much as we're being educated in terms of our barriers, because there are some significant barriers currently in hospital building code. And maybe those will change with the efforts, that as we learn over the number of years that this journey will take. But I look forward to, really being able to be educated as well as assisting and educating the group as well. So we're very much in the infancy. There is no established plan that we plan on bringing next month, for example, but this is a step in the right direction.
That's what I'm saying. If we make the commitment to the charter, it's saying to the organization that we want to become participants. Right now, we're not in the throes of being able to do that because of everything else that's going on. I have lots of concerns because we're coming down with a new CEO. We're going to have elections this year, so that assigning to the representation may be a question as well.
I fully understand that, Chair Wong. I think that, and those things are valid. I would still recommend that the board approve the resolution, and if we need to let some dust settle with the election, a CEO search, and things of that nature, we can do that, and then.
That's what I wanted to hear you say.
You tell us when to push the gas pedal.
Okay. All right. Anything else from our board? Anything from our staff regarding the charter? Anything from our audience regarding the charter?
So, is this on?
Yeah, doesn't sound
Doesn't
good.
sound like it.
Is it on?
Yeah, I think so.
The red light?
Okay.
Yeah,
Now it's on.
there you
Okay.
go.
You knew I'd be here tonight, right? Yes. I'm very glad that you're considering this resolution. I hope you pass it. As you know, we have, by my account, I think it's almost a year and a half, been asking you to become members of the Climate Transformation Alliance because you are such an important institution in the community. You are a source of greenhouse gas emissions. We need you to be involved. I also want to say that I think that as you go on your climate and sustainability journey, which we very much appreciate your starting with having sent 2 members to the Clean Med Conference and also doing the greenhouse gas inventory, which is the first step in this journey. We'd like you to know that there are resources within the membership of CTA that would be very happy to help you. There's a lot of expertise in this community. We'd like to see you develop that climate action plan, and there's a lot of interest and help to this institution in doing that. So I think that there's a benefit in your membership and getting to know the people in the community who are working on these matters. This is a very climate-activated community. There are lots of resources, and we all want to help the hospital district. So I hope you will take this first step. I should tell you that while we ask that there be a member of the board as well as a staff member who attend meetings, we understand that that's not always possible, and most organizations try to do that, but sometimes it doesn't work, and we understand that. But we think it's really important for you to make the commitment to be there, to be a part of this community, to use the resources. We all are in this together. The climate is not waiting for us to take action. We have to act with ambition and urgency, and your joining this organization would be part of your commitment to do just that. So thank you.
Thank you for your input, Deirdre. All right. If I could have a motion to approve Resolution 2024-07.
Also moved to approve resolution number 2024-07 to endorse the Climate Transformation Alliance Charter.
And a second.
I'll second.
Okay. We have a motion and a second to approve the Resolution 2024-07 to endorse the Climate Transformation Alliance Charter. All in favor? Aye. All opposed? All right, we've got our first step.
Thank you.
Okay, thank you. Our next point of action is our board culture and norms. Last April, the governance committee was given the charge to review what we were calling the order and decorum document. And the interest of the board was to make it more of what we believe and value in terms of being a board. So we, at the retreat, called it board culture and norms. We did send out requests to the board members to put in what they believe were the beliefs and behaviors and values that board members shared. We also took some of the information from our order and decorum that we felt was appropriate for our board. And we put it together in the document that you have in your packet as a draft of board culture and norms. We're going to get used to saying that name. And it will give us a structure for our board that will support good governance, that will foster trust and enhance the overall effectiveness of our board. It is only a draft. It's ideas that have been put together. It's been reviewed and then reviewed again by the governance committee, and now it's brought to the board for further discussion and hopefully approval.
My compliments to the committee who put this together. This bullet point format, to me, is so easy to follow. And I think it's, the previous one, Ted, was great, covered a lot of points, but it seemed like it was cobbled together over a period of time. And it was difficult to read. This is really easy to find exactly what you're looking for. And so the format alone, to me, is a big step forward.
And we try to divide it into areas of board interaction. Who does the board interact with? One another, with their CEO, with the staff, with the public, and then how do we run our meetings? I think the order and decorum really came from how do you run a meeting? And we know that from the Brown Act. So we thought, well, let's minimize some of that discussion about how public should be behaving and look at more of what our behavior should look like and how it should demonstrate our values.
Alice?
I think there were some people that had comments.
I'm trying to get your attention over here. Yes, and I would like to echo what Dale just said in terms of the amount of work that went into this, and it's very much appreciated. I have a couple of questions. First of all, if it's, I question the necessity of it to start with, but, because I think if these are our norms, this is our culture, and, the necessity for the document kind of baffles me. But I do have concern about item number 35, which is the public or staff concerns expressed to board members should be shared with the president and CEO. I think given our recent history, this sentiment has been questioned in the past, whether or not this is something, although it has the word should, it still sounds like a mandate to me. And I would like to see that particular item eliminated.
Any other comments about 35 that you want to say in support or elimination of this?
Well, I wanted to address your first comment about the need for the document. I think it becomes valuable if there's a new board member.
Yes.
Right? I mean, and perhaps as a reminder, every now and then. But that's where I would see the utility of it most. I understand the intent of number 35, but I also think that the professional discretion of the board members needs to be respected. And the word should, it does allow for that, to say, or.
So, I'm sorry, are you supporting how it's said, or do you want to change it or eliminate it?
I don't know if I feel as strongly about eliminating, but it's basically saying, if you hear some things out there, that the CEO needs to in some ways, we're the eyes and ears of the public, right?
Yeah.
And to be able to share that with the CEO, but it should be based on our professional discretion. I think we've had, in recent past, issues where, the CEO may not have been the best person to hear of something. We needed more information, or it was a private matter, but again, we're all grown adults and professionals here, so I think it's up to our discretion as to what should be shared and what should be perhaps discussed with just the board.
Yeah, I would just quickly say I appreciate that comment, Director McGarry. Actually, I appreciate both comments because I think, we've been through a time period where there may be some heightened concern about number 35, but in most cases, and in an ideal state, really what that's meant to do is that if you are hearing something that staff here at the health system can actually, potentially insert themselves into, maybe a billing matter or, a patient experience matter, we can actually improve that, hopefully. And I think a number of you, just in the past 4 months, have reached out and shared information with me that I shared with staff and hopefully made that experience better for that patient. I think when you have unideal situation, which, it can lead to, concern over that statement. So the word should, I think, is giving some discretion to the board and how you want to interact if ever there was a situation you needed to do that.
I just wanted to add, when examining similar statements or policies, if you will, by other bodies, so counties, for example, because I did do that. This is a pretty common best practice that you'll find in the towns and the counties and other special districts. And I think it does require discretion of the board. You're not going to run to the CEO with every little thing, but if something is a material issue, it's a good practice to alert the CEO. And I understand where we're coming from because of recent times, but let's not let that mar what is generally considered a best practice.
Yeah, I think we're all very sensitive, a little
Yeah,
PTSD here.
understood.
But if it is at the discretion of the board member, if that's what we're going to rely upon, that we should use our discretion, perhaps that's the way the thing should
To
be
be read.
stated.
At the discretion
At the discretion of the board, at the discretion of the member.
And can I ask for just some clarification on item number 40? First off, when it says interactions with staff, is that AC? Is that the 1,300 people that work here? Number 40 is use discretion when meeting in public places to avoid the appearance of bias. I'm not sure what bias we're talking about. My kids grow up playing sports with, probably 50 people that work here,
I remember Bob and I having this
I meet with
discussion.
them in public all the time, and I'm not worried about bias.
We ruminated over this as well. I think that, and maybe it's not doing a good job of describing it, but when the board members are in the same place, even though you may be grouped together and talking about something completely unrelated to the health system, it can have an appearance that you need to be sensitive about, I think is what we were trying to capture. Bob, do you recall our conversation?
Well, yeah. First of all, I have to say, this was a writing project that Ted and I did, and Martina too.
Yes.
And we spent a lot of hours doing this. And what we had before basically was a mess, and it wasn't written very well.
Yeah.
So it took us quite a while to come up with that, and then Alice did a great job editing. Once we had looked at it so many times, we couldn't see our own mistakes, and so, thanks to Alice, I think that a lot of this, where there was maybe not good clarification, got clarified. So I'm very gratified that there's only 2 points that, the board has.
So far.
So far, yeah.
Not done yet.
So anyway, going back to 35, that is a sensitive issue, and That's why we use the word should. So we're just saying generally you should, but you don't have to. And so we think that the word should implies that's the discretion that the board member must use. And we can add language like in the board
Discretion.
member's discretion. Would that satisfy your concern if we added that?
Yeah, when my mother said should, it wasn't.
Got
You know?
it. Yeah. We'll put in the
Okay.
words discretion.
Yeah, okay.
So we can modify 35 in that regard. So now let's go to
40.
40. This is, yeah, it doesn't have to be in there. It's one of those things that is kind of about best practices. I mean, really, it's all comes back to right under purpose, where he said a board member's conduct should reflect the mission, vision, and values of the health system and all engagements with other board members, staff, and public. So I mean, that's really what we're talking about. So it's kind of rare that there would be a situation that would come up under 40, but it's just kind of like a heads up. Beware of your environment, you know. Beware of who's watching what you're doing. Don't create concerns where none need be created. That's the whole concept. So I don't know if that is written in the best way for that, but that's the thought behind it.
And again, I think when we say interaction with staff, we're really talking about leadership. We're not talking about the nurse on med-surg who has your daughter on her soccer team.
Yeah.
But we're
It
talking
might be
about,
worth clarifying that, because staff is a very broad.
right, it can include medical staff, it can include nursing staff, it can include everybody. But I guess when we did that originally, it was really talking about the AC and leadership. So we can
What
change
number
that.
are you on, Alice?
Interaction with leadership, with staff.
You're on 35, okay.
Clarify that interaction with, rather than staff, leadership. Because when you go into it, it's talking about when you have something on the agenda, we want to give you notice early enough so that we're going to pull your item and we're going to have a question about something, so that you're prepared to answer it. Because if we do it coldly at the meeting, you might not have the documents to give us the data on it.
Well, that's a different point. 35, the word
Oh, no,
staff is so that,
No,
talking
I know
about
what that
every-
is, yeah, but we were talking about interaction with staff, which 40
That's a
came
different
under.
question.
Yeah, 40 comes under that. So I
so
was
you're on
just,
40 or 35?
I was on 40.
Well, the word staff is used in 35, public or
the
staff
header.
concerns, but
That's general.
that's
yeah.
just general staff, but then interactions with staff is not general staff. So I think just
Yeah.
clarifying what we mean by staff would be helpful.
And is
Potentially,
leadership
you could say
what you're
staff
looking?
and leadership if you wanted to. Want to be mindful that there are 1,300 people here, and yes, you will likely engage with leadership much more than the other 1,280 or so. But I think it's really important that the board, or that the staff, every staff member feels that the board also engages with them or values them as well. And I think you did a nice job by incorporating that in interactions with staff. So I would just really, put to you to consider, if we did change that to just interactions with leadership, it could have unintended consequences.
Agree.
So we're going to say use discretion when meeting with leadership in public places to avoid the appearance of bias. Is that the suggestion?
On 40.
Yeah.
Under
Would you
40?
mind, Director Barnett, saying that one more time? Sorry.
So you're suggesting we revise 40 to read as follows. Use discretion when meeting with leadership in public places to avoid the appearance of bias? Is that?
I was actually making a comment on the actual title of that entire section.
Oh.
Number 40, I understand, it may show up as a best practice, and I understand the intent there in terms of what could look like bias, but, we do live in a small town, and I wouldn't want to give people the feeling that because there's board members potentially in the same location as staff or leadership, that there's really any business of the hospital being done anyways. And then this kind of assumes, or one can assume, that if there was a meeting happening, that there's a sense of bias occurring there, when really it could be just good work of the health system. So that entire statement essentially concerns me. But if it's best practice, I think we could maybe rewrite it to where we're actually getting the intent from the statement.
So let's go back to the title, Interactions with Staff. What would be your suggestion for changing that title?
Just leave it.
No change.
Oh, okay. So I have mixed
This should
feelings
just
on 40, you know.
Yeah.
I would be happy to see it disappear, because it might be more problematic than useful.
Yeah, that's where I'm going too, Bob.
Which one?
40?
It just isn't necessary. I can't think of enough opportunities for improper behavior that would occur, and
And I think it falls in the other category, as I explained before, about, you know, the conduct should reflect our mission, vision, and values in all engagements with other board members, staff, and public. I think that kind of is
Sets it.
what we're really trying to do.
Yeah.
So subject to what the board wants to do, I think we could just eliminate 40 and we'll renumber them. Martina knows how to do that.
Okay, any other statements that you want to have revised or reviewed?
Can you explain 39 to me? How that would be?
Okay, there's some history here. Okay, some submittals for inclusion, say, in a board packet. Martina's very rigid on when staff has to have things to her, or it's not going in the agenda packet. Okay, on occasion, there may be an issue brought forth by a board member, and the same rule would apply. I think is what we're trying to say.
We need to have a statement around all of that?
Well, there's some history here. The problem was chronic in the past, and that's why it ended up in the order and decorum document. Martina can address whether it's chronic today or happens occasionally. What's your experience now? Maybe we don't need it, but it did come out of bad behavior in the past.
Yeah. And again, it was something that might have existed. It's a whole new board now. So I think we could go ahead and eliminate it. And that Martina continues to let people know that board review, agenda review happens at this time. If you want to be on the agenda, you need to submit your packet by such and such a date.
The other thing I would also suggest is that Martina is exceptionally good at sending a rather stern email to you when the deadline is quickly approaching. So
Yeah.
you'll get the same thing.
I'm more mindful of that than this document, for sure.
Yeah,
Yeah.
Okay, we can eliminate that.
All right, so 39 goes out. Are you taking notes?
Yeah, she's got it.
Because I am too.
39 and 40.
5 are changed, 40 is out, and 39 is out.
Yeah. And 40 is being revised using word discretion.
Correct.
And then the one thing that I'd like to say is that this is a document of our values and how our values come out in our behavior. And I would like to see all of the items start with what the behavior is, because some of them say the board member shall. Well, it's all about the board. So could we just not have that at the beginning of the statement and use that the use of e-commerce by board members during a public meeting of the board is prohibited? I mean, something like that where the behavior comes first.
What numbers are you talking about?
That was it was number 9.
I don't know, I think it's pretty clear.
Right, but what I'm asking is that every other one of those are behaviors. That one doesn't start with a behavior, because what this is are our behaviors as a board. And if I'm getting too picky, just say that.
No, I saw the same thing as I was reading through.
Yeah,
this.
because it's intermittently you see it
It's very
happen.
inconsistent.
So it should say something like e-communication, utilization of
Yes.
e-communication by board members during a public meeting is prohibited.
Right.
Yeah.
Okay.
And then going on
Okay,
to
let's see, that's number
9.
9.
And then number 10, we would like to revise that one, so the behavior comes first, to speak or to have an opportunity to speak for public input or for additional staff input should be made through the board, through the chair. And then 11 would be a revision also. It has all board members.
Wait, how are you going to change 10?
10, I don't even have to say that, I have to think about it again. To speak during a meeting for public input or for the additional staff input should be made through the chair. So Mary says, Alice, I'd like to speak on that.
Aren't we saying that?
It may not, but it's one of our behaviors.
Well, it's a request, it's not a behavior. If you make a request, this is the way you do it.
Right. A request is a noun. What I want to start with are all of them should be how we behave. So I would start with to speak, which is a behavior, for an opportunity, for public input or for additional staff input. I mean, we don't have to take time to do this, but again, it would be something that we would want to relook at.
It's going to come back to our committee, we can do another revision and see how that works.
Well, we review this annually, typically at your retreat in the early part of the year. We do it because, we may have new board members, but we can bring it back, we can adopt this with the modifications made tonight, and we can continue to work on it and bring it back as we normally do at your retreat. And if there's changes we need to make, we can do it then.
Have you considered running this through AI?
Oh,
Seriously? Huh?
Yeah, but I
Wait.
rejected the idea.
You rejected
It
the
might-
idea?
Might be
yeah, we
fun.
haven't asked anybody in the audience or any of our staff, have they looked at
Yeah,
it to
is there any
say,
input from
do you have
anybody
any
else?
input? No.
Why don't we just vote on it once it's refined?
We can do that.
Want to send it
Bring
back
it
to
back.
committee,
Yeah.
and we'll work on it? That's fine.
Okay.
Okay.
We can run it through AI in the meantime.
Yeah, I think.
Yeah, and then we have to go redo it.
Oh,
Okay, so,
I'm an active user.
And just a reminder, it's a guidance document,
Yeah,
right? Like,
it's a-
no one's
yeah.
getting fired because of it, no one's going to jail because of it. It's just a
it's
guidance.
how we can guide ourselves in being the best board we can, plus it gives the guidelines for all future boards. And as times change, they too will want to look at it and say, well, that's not even applicable anymore. Yeah. So, legal counsel, what do we do about that? Because that was up for a motion.
Yeah, since it is an action item and you are authorized to review and consider approval, I think we would have a vote to send it back to the committee for.
Back to governance or
Yeah.
Okay.
the committee of Bob and Ted.
Okay. Can I have a motion of what we want to do?
I move we send it back to committee.
Can I have okay, so it's been moved a second to send board culture and norms back to governance committee for revisions. All in favor?
Aye?
All opposed. So governance, you've got your walking papers to do. So thank you on that, everybody.
We're happy to
Okay,
work on it.
we have pulled an item for the CMO report. Dale, you were the one that pulled it. Can you talk?
Yes, I can. When I read Brian's report, I wrote to him and I said, Brian, as you're well aware, for many months, the board heard directly or indirectly from some, arguably many, in the physician group about the admin failure to exercise good listening skills and the lack of collaboration and decision-making in a top-down leadership model. I was fortunate to be included in the recent Mayo Clinic presentation of their dyadic management structure that successfully deals with this. In your CMO report to the board this month, under People, you provide us with a brief description of your work to implement this model, and I think that I and others, board members, perhaps would be interested hearing more about the progress being made and its understanding and acceptance by the medical staff. So,
Absolutely, yeah. It's a great question. I'm glad you asked it, Director Chamblin. So there's a lot that we could discuss. I mean, this could be a lengthy discussion, and after that last section, I probably want to make it a little shorter for the rest of the group. But I believe this is a very important area of opportunity for this healthcare system. We all know that there's been major concerns about listening, about transparency, about shared decision-making, about communication, about respect, and those kinds of things. So there's been a lot of work done, and we'll talk about a few examples of that. I want to start with service line leadership workshops. So I'm sort of in the middle of that series of workshops right now. They've been here in Eskridge, and they've involved our service line dyadic leadership teams. So you should all probably know by now there's 27 patient-facing service lines. So these are departments where patients are being seen. And each of them now has a dyadic leadership team, so an administrative leader as well as a clinical leader. You saw one of those dyads here today.
Right here
You saw the behavioral health dyadic leadership team. You've seen others previously. So they are becoming much more well-established, and the way that we're interfacing with those dyadic leaders is different now, I would say. So we had workshops in this room to really ask a number of fundamental questions. Louis was there, Scott was there. We talked about, first, what is the culture that we have at Tahoe Forest, good and bad, okay? And we were very candid about that. And we really talked about what do we want the culture to be. And this was a very open forum, very transparent forum. And then we asked a very important question, which is, if we are to elevate clinical leadership and the service line leadership of this organization, would that have an impact on the culture of this place? And if we were able to move it in the direction we want it to go, what would be the effect of that? What would be the result? How might our quality be different? How might our financial performance be different? What would that do to engagement? What would that do to turnover and many other things? So I think what I heard in this room on the 2 workshops we've had so far was very clearly that the culture would improve dramatically, and the engagement of the entire medical staff would significantly improve, and many other downstream results would happen. So that was a really key component of that service line workshop that we did. We then talked about what are the attributes of leadership that you would really want to see if you were to move that culture in the right direction. What do we all need to agree to as the service line dyadic leaders, but also all of us in this room, the senior leadership of this organization? What kind of attributes would we want to see? And so there was quite a bit of arguing, quite a bit of debating about what that might look like. But ultimately, we ended up with a pretty coned down list. It's about 7 items long, and I'll share it with you at another point. I can go pull it out of my backpack, but it includes things like emotional intelligence, very clear communication.
Right here. Want me to read it?
Did I put it in there?
Yeah.
Yeah, it's emotion, number 1, emotional intelligence. 2, knowledge and expertise. Number 3, communication. Listening, critical thinking. Number 4,
Curiosity.
kindness. 5, integrity/accountability. 6, collaborative and /adaptability. 7, curious, and 8, inspiring.
Yeah, and there was some coning down because I think the list you read was the first workshop, and then when we ended up compressing it into a final list based on input from the second workshop, and we still have another third one to go, kind of a makeup session. So the question was, if we could all embody those leadership characteristics, would we move the culture? The answer was yes, absolutely. Everybody agrees on that. So we talked about some other things in these workshops too. We talked about, well, what do you do if you're a leader and you may not be getting 100% on all these attributes, right? What do you do then? And we actually went through a process where we did a self-evaluation in these workshops for each leader, and they had to decide how they're doing on all these things. How good of a listener am I? I can tell you that no one scored 10 out of 10 on all attributes. No one. So that just tells you that at least we all know, and this myself included, that we all know we need to improve on a continuing basis as leadership. So we talked about development opportunities that we have within the organization. We talked about external ones. And we also are committed to providing customized leadership development programs for individuals that really want to kind of up their game, as it were. And I'm already talking to a few people about how to do that. We also talked about how we communicate within the service lines, across the service lines, and with the entire system. And we talked about meeting structure. So one of the things that we're doing, and Scott has probably heard me talk about this a million times so far, because Scott and I meet with all the service line leads, right? We do this regularly. Every week, we're meeting with service line dyadic leaders. And we talk about communication, and at the end of the agenda for all these meetings is communication. How do we make sure that the people that aren't in that room hear what we're talking about and have the ability to contribute to these meetings and inform the next agenda? So it's this bidirectional communication pathway. So I can tell you it's starting to really gel. It's starting to really make a huge difference. I'm getting a lot of positive feedback about it. I think it's interesting that tonight we had the behavioral health dyadic team, who are the newest dyadic leaders. You heard them say they've been here for a couple of months, basically. So they don't come sort of encumbered, I guess I would say, from any of the past stuff that we've had to deal with. They're just ready to roll, and they're hitting the ground running, which is great. Others are coming along, and it's a little bit more of a process, I would say. But I think it's making a big difference. So good stuff happening on the service line. I'll talk about a couple other things. The Perioperative Governance Committee. This is an example where there's been a tremendous improvement over the last 2 years, really. When I first came to this system, the PGC was brand new, and it was not highly functional. And I'm not going to say I changed the whole thing personally. I'm going to say it evolved through the work of many. And it has now become a much more effective group. The decisions that are made there affect surgeons' lives and the lives of lots of other people as well. And so it's very important that that body have some kind of connection to the medical staff, and it's felt to be representing their interests effectively, and it really is doing that, actually. And I think that the surgeons and others really appreciate the work that's being done. And sometimes decisions have to be made there that are difficult. You know, like we're going to take someone's block time away, you know? So these are material things that are being discussed. We had our PGC today, and I was reminded that it's really gone on a journey. So I think that's been a very good thing. The other thing is I want to talk about values-based decision-making. So sometimes we're faced with a very significant decision that affects a lot of medical staff members and lots of other people as well. So one example of that is where are we going to house different service lines in what buildings and what floors? Where are those folks going to be located? And you can imagine the angst that that kind of a decision might cause. So one way to decide it is just to tell people where they're going. That's top-down leadership, and we could do that. We have not done that. Now we're going through a process because we have multiple different service lines that are probably going to need to relocate based upon end-of-life buildings, new construction, licenses that we could take full advantage of. There's many different moving parts, and we want to figure out where to put folks. And so we haven't made final decisions on most of them, but we've been going through a very robust process of talking to the medical staff members, especially the service line dyadic leaders, and saying, you know, here are the pros and the cons. How does it affect our values? How does it affect these peaks? And when we talk about moving, you know, one service line to another location, it has an effect on all five. It really does. And some more than others, and some in an outsized way. Oftentimes there's a huge financial change by moving a service line from one place to another, and you might be thinking, okay, well, we're obviously going to move them because there's a big financial pickup with this. But we also have to think about safety. We have to think about quality. We have to think about engagement. How are patients going to feel about it? Does it improve access or reduce it? What mitigating factors? So we're going through a much more robust process of deciding how to do this by informing the key people that are involved in this. So I think it's really important to do that. Those are just some of the examples I think that are showing up now. I think that I've gotten a lot of positive feedback from people. Oh, I want to mention also surveys. So we've just recently gone through a debrief with the medical staff on the Press-Ganey survey, the physician and APP engagement and alignment survey. So we shared all the data. We sent the survey results to them. We took all their questions. We really reviewed what the survey had shown and then also what we're doing about it, essentially. And so the feedback I've gotten from those debriefing sessions has been very favorable. Did the same thing with the SCORE survey pretty recently. We're getting a little survey overload now, but I think it's a really, I think things have changed, and I think it's going to take some time before the entire culture changes with it. And I'm not going to say that we're there yet. We're not even close. We have a long way to go. Culture changes usually take years, but I think we're well on our way.
What about morale? How is the morale impacted? You know, we had a number of healthcare providers and medical staff that were, had conflicts with the previous CEO and were offended by
Yeah.
that. And it seemed like that sting stayed with them at least for a while. How is that issue working?
Well, go ahead, Lee. Okay.
We haven't put out another survey and asked particularly about morale, but I think this is subjective, right, the question. I think for all the reasons that Dr. Evans just brought up, we're involving them in decisions. Sometimes it can take, a longer time to do that. It can, potentially involve more people, but it's a much more rewarding experience when we get to the other side. There's a lot more ownership. Recently just saw obstetrics looking at the plans of where their new clinic may end up in and being involved at that stage. I mean, it's a rewarding experience rather than just a top-down, decision-making experience. And I think, in general, I'm seeing people as we walk through the health system smiling. I'm seeing communication that, maybe others would have walked other ways and kind of scurried out of a hallway. Stopping and chatting with each other. I'm not seeing people showing up here to the district board with negative comments. By no means are we all the way there, right?
Yeah.
But again, just subjectively, I think people are, really finding some hope and, really looking at the future as being the great place that they know this place is. So I think, again, I've used this already today, but this is a journey, and we're well on the way of that journey. So it's precious. Each decision that, needs to be made, they all have either really positive benefits that can come from it, or it can potentially set us back. But, we're here as a team that even if we have to step back once in a while, we're going to try and take 2 steps forward. There's a lot of effort here in improving not only our healthcare system for all of the employees and providers, but also for the community that we proudly serve.
If that culture gets totally embedded, do you see your service line providers and administrators looking to the nurses, looking to the office workers, et cetera, for their input and their involvement in the whole process as well, too? Do you think it ultimately could become that pervasive or should become that pervasive?
Yes. It's absolutely imperative that all the members of the entire service line are involved in discussions and in decision-making to some extent. And so I've seen in some service lines there really wasn't any sort of formal mechanism of making sure people knew what was going on, or that they were going to be able to inform a meeting agenda, or there was no huddle board, there was no huddles, there's not a lot of anything going on. And so we're building that out in all of the service lines, and we've made a lot of progress. So absolutely, everybody and everyone is equal. There's an expectation that everyone will be involved going forward. So that's part of what we talk about at these service line meetings, and just make sure those mechanisms are in place.
Well, thank you for that.
Yeah.
Thank you for the explanation. Thank you for the question. Now we have to vote so that you can be included in the consent agenda. Oh, I'm sorry, yes. Any comments from the audience? Okay, then we can have a motion
To
to
approve.
accept.
I'd move approval of 13.3.3, our CMO board report.
A second, please.
Second?
Okay, so, sorry, I'm losing it already. Can I have a vote on the CMO report being accepted? All in favor?
Aye.
All opposed? So it is added to our consent agenda. We have board committee reports. I think governance was the only actual board committee that met, and you heard about the culture and norms document that will be going back to our committee for editing and revision. We also worked on the retreat work plan, and anybody that was named as a leader on the plan should have received their work plan that came out of retreat. And we've made it into a dashboard, or we're making it into a dashboard that will be on the Board Effects so that we can watch progress. And things that are done will be red. Things that, no, that's not right. Things that are done are green.
Hopefully.
Yeah, green. And then those that are being worked on will be yellow. But you'll see which ones have been completed and which ones. And again, it comes from the huddle boards and some of the really effective tools that the dyadic leadership and the service lines have been using to continually move their goals. Is there any report coming from any of our foundations?
Yeah, we met this month. If y'all recall, the foundation board opted to take some meetings off-site to be more work sessions. That was one of these. So it was just a lot of work session on the upcoming 75th anniversary event in November.
Okay.
And I learned a lot about auctioneers.
Yeah.
It was great.
All right. We look forward to that event.
I informed Carly Epstein that I was going to be out of town and asked if she thought it was important that I have a board member sit in for me, and she said missing one meeting isn't going to make that much difference. The meeting was held at Rayleigh's, was it not? Yeah.
It was held at Rayleigh's.
Yeah.
In Incline Village.
In Incline Village, Rayleigh's, yeah. What, big office or what?
It's a community room, and it's at the front of the store. It's beautiful and has amazing artwork. It's really conducive to community type meetings, so I enjoyed being there.
Yeah.
Julie Teal offered that place for all future meetings if we would like. I don't know if there was a commitment to do that exactly at that point, but
Yeah.
I'm sure you will find yourself in that room. It was a vigorous discussion, just kind of from summer activities and thinking, about the future in terms of activities for maybe next summer. That is a great community over there that's always looking for ways to support that Incline Village Community Hospital, and that's what the discussion was essentially about there.
Are they all set up with audio-visual and so forth, or?
They do, yeah. They have
Okay.
audio-visual. You can do Zoom meetings from there, and
Yeah, okay.
do your grocery shopping while you're
Are they going to do a golf tournament again this fall?
We are doing a golf tournament, and funny you should ask, it's actually on Sunday. So
Yeah.
we will be doing a golf tournament. There's a few of us in the room that will be out there. One of us defending their title there. I won't mention who that is, but it's me. No, it's not because of me. I had a shark on my team. So, but in any case, it should be a good time, and that's put on there by the North Lake Tahoe Ladies Auxiliary. And so they do a wonderful job for us as well, and really donate that money back to the hospital in terms of scholarship opportunities and various other good initiatives. So we very much appreciate that, and it's a great event.
Thank you on those. Just a quick reminder that the board will be attending the Association of California Hospital Districts in Sacramento next week. And hopefully we'll be able to bring back some meaningful information from that particular meeting. Also, I want to let you know that our leadership profile has been approved. We took all the information, I didn't do it, but the information from our special session was filtered through with Kiefer to put into the profile. Things that the public might have added were really already embedded into the profile, and there was some new addition, and especially when there were certain groups that felt that they were not, the profile was not inclusive. So we worked on that. We should be hearing from with Kiefer about a meeting that we'll have to go through the next steps in the process.
That's
And-
Tuesday at 3:30, right? That what Kiefer meeting?
Yep.
Yeah.
Yep. Okay, so I'm sorry, I've been distracted and I forgot where it's going. It's past my bedtime. But anyways, they have already been receiving applications or resumes for our position. They have the position up on their board or their website. And now what they'll do, now that the finalized of the profile, they'll start matching up resumes with the profile to see who's meeting most of the requirements or the attributes that we want. So we'll hear more from that in the next steps in our next meeting with Whitkeefer. And that's all I have. Does anybody on the board have any last comments beside the golf course,
See, we
the
have
picnic, the...
Do you want to bring us up to date on what's happening on October 6th, that event?
It's the picnic.
We're going to hold a community fun run, so it's a fall fest and fun run. The foundation has assisted us in celebrating our 75th anniversary with the community, and so we look forward to a great day on October 6th. There's activities that generally will be very fun for the kids. We have a number of vendors that will be out there as well that will be fun for the adults. And we have a race. I don't think it's I guess it is a race. They're going to time us. So unfortunately, you're going to see my very slow time. But you can either sign up to do a 5K, a 1 mile, and also there's just kind of kiddie races as well. So right now you can go onto our website and you can actually find a link to the fun run and you can sign up, and the more the merrier. We're hoping to see a lot of involvement from the community.
You're promising good weather?
I'm hoping on good weather. We're watching that very closely. So, but we will be out there, rain or shine, and it has kind of a Halloween theme. So I believe that there's also costumes that can be worn for the run. So it should be a good time. There's actually you may have seen it as you go into Glenshire now, there's a billboard that Ted and Meg and their team put together that actually shows the fun run. So we're really trying to get it out there to the community. Hopefully a few of them will watch this, go to our website, and sign up.
Okay. Any other comments?
Nope.
Okay, if there's no further comments, this meeting is adjourned.
Good job, Alice. Finished off there.